Welcome to the third episode of Sleep Lab with Netzer and Popovic. And as promised, Rainer mentioned it in the last episode, we want to show you today exactly what happens in a sleep lab, also with the aim of helping you lose any fear you might have about such an examination.
It's quite remarkable that most people who are referred to a sleep lab don't actually know what happens there. That's exactly what we want to show you in this episode. Very often I hear the comment, but can I even sleep with all those wires and sensors attached? It is possible. Sometimes, though, we might need to help a little with a sleep aid. What's important is that we get about 6 hours of sleep recording, which we can then interpret afterwards.
But we're not doing this in the studio. Instead, we're going to a real sleep lab at the Melita Clinic in Bolzano. A warm welcome to all those interested in sleep medicine. We are now in the sleep lab with Petra Waldner. She runs the sleep lab here at the Melita Clinic in Bolzano. And in addition to Petra, we've also brought in the highly experienced Heike. She has been a dedicated sleep medicine expert for many years and has also meticulously written a comprehensive guide specifically for technical staff working within the sleep laboratory. It's the best resource I know of on the subject. Heike, the way you described it so beautifully, making it easy for all of us to learn, I haven't seen that anywhere else, not even in textbooks. Petra, you can confirm that, right? Of course, great thing. And today, Heike and Petra have also brought a model with them for us. This is the case sit, and the two of them will now demonstrate how to wire up patients using it. I'll just briefly jump in again. I'll give 2 or 3 explanations, but dear Heike, it's your turn.
We're now going to start with the wiring. So I ask you to please stand up for a moment and lift your t-shirt a bit. We're now attaching the ECG, which records heart activity.
I'll just jump in again for a moment. The ECG is also important in sleep medicine because the heart activity and breathing activity naturally occur together, or rather, we can draw certain conclusions from the interaction between the heart and breathing. And of course, logically, later on, when we connect the encephalogram, the EEG electrodes, the heart activity also plays a role here.
Next, we'll attach the leg electrodes. Please lift your pants up a bit. We have the right leg and the left leg because even during sleep, there are movements of the legs that need to be recorded.
Perhaps it's important for our viewers to know that the movement of the legs is important not only in the case of restless leg syndrome, which you may have heard of, but also for us in sleep medicine as leg movements in connection with arousal reactions after an episode of apnea are significant. These play a major role for us, and as we'll see later on the computer, you can clearly distinguish between leg movements that occur as a result of arousal reactions and those that are completely independent of them.
Now let's take a look at the device itself. This device records both the position, which is very important because of course there are also position-dependent disorders. For example, simply due to anatomy, when lying on your back, it naturally falls much more easily and quickly backward, which can trigger apneas. It falls back much more easily, much faster, and can thus trigger apneas. This here is the abdominal sensor and this is the thorax sensor. With these, we record the movements of the thorax and abdomen. Interestingly, when there is an obstruction, the thorax and abdomen move in opposite directions. That's why both are very important. This is the cable splitter for the EEG.
Maybe a quick word about the belts. Heike just mentioned it. during an apnea as it typically occurs in sleep apnea. So, for example, there's a pause and then the breathing starts working against itself to try to reopen the obstruction. In contrast, when a breathing pause originates from the brain, a so-called central apnea, the breathing movements are synchronized, and this is crucial for us in sleep medicine to distinguish between an obstructive apnea, which is a breathing disorder caused by a narrowing in the throat, and a central breathing disorder triggered by a missing breath, a missing breathing signal from the brain.
All right, we'll continue now with the EEG.
Exactly, and for that, let's head over here now. And we'll have the patient sit very comfortably in the chair, because that's also a much more comfortable position for the people connecting the equipment in the sleep lab. Maybe just to mention, with the case sit, we've chosen an extreme case for you this time, because normally for me it would be a bit easier to attach the electrodes. He has a nice thick head of hair. Now the ladies here are really challenged when connecting the EEG or the neurophysiological channels.
All right, now we'll measure the head. First, we will measure from the nation to the Indian, and then we will carefully mark the exact midpoint.
That was a very nice medical explanation, Heike. For our viewers, that's from the tip of the nose all the way back to where the cervical vertebrae begin.
Should I open this? Yes, that's right. Sometimes we speak in our own professional jargon. Now we measure from everything's fine, from preauricular to preauricular, so from the hollow on the right side.
The bone you can feel below, called the mastoid, here below the ear to the one on the other side.
And exactly through the middle. These positions are so important. We wire everything here according to the AASM, the American Association of Sleep Medicine. And we want to do everything correctly because we will be attaching various electrodes. We will attach a frontal electrode. The frontal electrodes show deep sleep beautifully. The central ones basically show everything, and the occipital ones, which we will attach later. There you can clearly observe the difference between sleep and wakefulness. That is, this transition, this shift from sleep to being awake. And if you consider that you have to analyze 900 pages of EEG to create a so-called hypnogram, then you really place a lot of importance on good electrode placement.
Exactly, what Heike just said is very important. As I said, in the end, what we're doing is picking up electrical currents that come out of the brain that radiate outward. By the way, this might be interesting for you, dear viewers. A human brain emits about 100 watts. So with that, we could power 10 or 20 LEDs. So Casey could basically light up this whole room with his brain. So we take this current and detect it using the electrodes. And what Heike just explained, the measurement. There's actually a term for this. It's called the Jasper system, and we'll take a quick look at it in a graphic now.
When placing the electrodes in a sleep lab for an electroencephalogram, or EEG, the Jasper scheme is used as a guide. This method aims to cover all brain regions and to assign the measured electrical currents to their corresponding areas. The scheme is relatively simple. A line is drawn from the bridge of the nose to the back edge of the bony skull, while a second line runs between the bony protrusions near the earlobes. The intersection of these lines is referred to as the cephalon central, the center point of the head. Along both lines, points are then marked at 10 and 20% intervals of the respective line length. In the EEG of the sleep laboratory, electrodes are not placed at all Jasper points. Instead, they are mainly placed at the points C3 and C4, each 20% away from the center point on the line between the ears. It is also recommended to place electrodes at the points O1 and O2, each 10% away from the line between the nose and the back edge of the skull, as well as at the points F3 and F4, also 10% away from the same line and near the front of the forehead, to record currents in the frontal brain region. Additionally, 2 electrodes are placed below the chin to measure muscle tension for the electromyogram, and 1 electrode is placed to the right and left of the eyes to record eye muscle movements as part of the electrooculogram. The currents measured at points C3 and C4 produce the alternating current waves in the center of the brain.
Petra has now marked the points that we are about to connect with wires. And for that, we have these gold cup electrodes here.
Maybe, Heikki, since we've both been in sleep medicine for quite a while now, why do we actually use gold cup electrodes for EEGs? Would you like to briefly say something about that?
Well, the results are simply much better than if, for example, you used silver chloride. They also come as disposable electrodes, but since we work sustainably, those produce a lot of waste. They do need to be cleaned, but in terms of sustainability, the gold cup electrodes are simply wonderful.
Even in the sleep lab in medicine, ecology is still important. But it's also important that we actually get a better signal this way. And the nice thing is we can attach them like this. The electrodes stay attached to the head, even with such dense hair as our model has here. Whereas with disposable electrodes, if we stick them onto the hair, they would just come off again. That's another reason for using these cup electrodes, which we can attach to the head with a special adhesive, even between the hairs. This way we get a very clear signal and capture the current well.
So now we have carefully measured from the very front of the head to the back, and then from one side all the way to the other side, and by doing so we have precisely determined the exact center of the head. And now it gets a bit more complicated because now we have to measure 20% of this distance to the side. Good. And we also mark first to the other side, exactly. Should I hold that for you? Great, good. However, we also meticulously mark 10% upwards from this precise distance here on both sides, ensuring accuracy. Yes, accurately measuring this out is indeed a rather complicated and intricate matter, but it is a fundamental rule that we absolutely should endeavor to follow consistently.
Yes, the reason for this placement of the electrodes is that in the end we have, in total, there are actually 6 electrodes if we follow the rules of sleep medicine. Heikki already mentioned it, the American Academy of Sleep Medicine, which is the American society that established and prescribes these rules. The latest ones actually come from the past few years. For a long time, there was actually a long pause. Then in 2007, there was a new approach to how this should be done. The crucial point is that we want to record different brain regions with this. So first here, the central area above the hippocampus, then at the back, which is basically in the region of the cerebellum, and the frontal brain, which is the most active for us humans, or the essential feature of Homo sapiens, so to speak. Other animals also have different parts of the brain, but only we have such a frontal brain, and that's what we want to capture with this as well.
Exactly, from this distance now. Here, these 10%, and now we take the circumference across. And from this distance, again, 20%.
We're presenting this nicely for you here, the 3 of us. Of course, you couldn't normally afford this much personnel in a regular sleep lab. The sleep lab staff usually have to manage that on their own.
Yes, usually that's the case. All right, okay. We've now determined the points. We've now identified the central point here. We've marked the FP here, and exactly in between the frontal point. And let's mark that again now, please. Now we'll place the occipital electrodes at the back. For that, I'd like to ask you to turn a little so we can see it from behind as well. We've already marked 10% upwards, and now we'll mark these 10% to the side. With that, we have the occipital electrodes. Remember, these show us the transition between sleep and wakefulness. Great. Okay, now we'll start with the wiring. That's always a bit of a tricky part, which...
The nice thing is that nowadays, thankfully, there's a combination of electrode cream, which basically transmits the signal through the skin, and an adhesive that secures the electrode in place. In the past, that wasn't the case. You had to work with two different components, almost like a two-component adhesive. Thankfully, we're spared that today, and it's also water-soluble, so it comes off the patient's skin more easily afterward. There's no need to worry. There's no skin damage, nothing at all. None. It doesn't hurt either.
You put them on, I'll hand them to you, since we're such a great team today, which, as I said, isn't always the case. Now we need to prepare the skin. Every skin naturally has some resistance, but we want to measure the potentials underneath, and the result of all our rubbing can later be seen in an impedance measurement on the computer. That's why we're preparing the spots now. I'll take a second swab, because first you need to gently rough up the skin a little bit, and then you absolutely have to wipe it completely off again. Now we're rubbing.
By the way, something I forgot to mention in my explanation, I had already talked about the sticking process, but before that, of course, comes cleaning the skin. There are always skin flakes on the skin, which would create too much resistance for the electrical signal, and those are now basically being rubbed off before we apply the cream, which does both. It conducts the electrical signal and also, so to speak, sticks everything in place. That means there are tiny little metal particles in this cream which make it possible for the electrical signal from the brain to travel through the skull, over the skin, and then to the electrode.
All right, since it's a bit hot here, we'll put a small cloth over this electrode. It's like a plaster paste. It will dry and then hold everything firmly in place. Okay, now we'll do the other side. So it's very important that we thoroughly wipe this area just once, ensuring it's completely clean and prepared, and then following that, we can carefully and gently apply the cream to the skin. Good, and secure it in place. All right, thank you. This is now the C.
So with the two electrodes we've just attached, we are now essentially recording the central area of the brain above the hippocampus. These are the most important electrodes for us in sleep medicine because they give us an overview of the entire brain before we now use the other electrodes to record specific areas of the brain.
Now, we will carefully proceed with the frontal electrodes. The precise placement for the first dot is right here, and then we will place another one symmetrically on the opposite side of the head. Following that, we will meticulously add the two occipital electrodes, ensuring their correct positioning. For this next step, I will utilize these particular scissors here, just one more time, to assist with the placement. Thank you. So,
just a moment, could you give me a small piece of gauze, then I can
find it. I'll do that.
Are you doing yourself?
Of course. So now we still have the two occipital electrodes to attach here. The cream, as you can see, it really is a complex examination, but what we can discover with it is immense. We can't yet see what someone is dreaming, but we can see when they're dreaming. We can see when deep sleep occurs. We can see every waking event that happens due to any kind of respiratory, that is, breathing disturbances. And I find it fascinating. I just find sleep fascinating, and that we can record it all so well. Absolutely brilliant. Now comes the very last electrode, which we carefully place in position right here. We then apply a small amount of conductive cream to ensure good contact. And there we go, perfectly in place. Okay, that's great. Following that, we use a soft, clean cloth to gently wipe away any excess. This is indeed the final electrode we need for the entire EEG setup. However, it's important to note that even with all electrodes attached, this comprehensive process is still far from being completely finished. Now, we still need some behind the ears as a reference. On the left side, we need one here behind the ear, and on the right side, behind this ear.
Exactly. Now we'll use electrodes again because they usually hold well enough here and there isn't any hair in the way. And furthermore, just to explain for you, dear viewers, what does a reference electrode actually mean? We've already explained before that the current that is flows from A to B, from the cathode to the anode through the electrodes. And here as well, you have to imagine that we basically have current flowing from A to B. It's like your power outlet at home, where the current basically goes in and out. We also know that the brain uses alternating current, and for that reason, of course, we need a positive and a negative pole for the current. So it's not direct current going back and forth, but in humans, the brain also uses alternating current.
Good. These electrodes behind the ear, for anyone who's ever wired this up, are extremely important, because if even one of them doesn't work, then the entire side of the head won't function. And the reference electrode is also added here.
The reference electrode, which is now placed on the front of the forehead, and for Silabo viewers this might be important, you can roughly compare it to the grounding in your household electricity. You know, the two side pins on a Shuko socket, that's basically your grounding. Of course, we also need grounding for the electricity, and in this case that's our electrode above the forehead plate, where the brain or the bone is very, very thick, and this basically serves as the ground for the electrical signals we record elsewhere. So
now the eyes will be wired as well for the EOG, the electrooculogram. The eyes are so important because when you fall asleep, you have rolling eye movements. In contrast, for example, to when you're awake and watching TV, the eyes move back and forth very quickly. But these rapid eye movements are also found during dream sleep, in REM sleep. But the difference is, and we'll get to this in a moment with the chin electrodes, in REM sleep, the body is so relaxed, all the muscles are relaxed, and you can see that on the chin electrodes. That means the difference between rapid eye movements while awake and rapid eye movements during dream sleep is the chin muscle tension, in other words, the overall muscle tension measured at the chin. For this, we move them a bit, once upwards and once downwards.
Thank you for saying that. What's important here is that we don't just want to record the eye movements. So for example, I move left and right, let me try to show it here, but also up and down, because that's crucial as well. That's important for us too. We have what is called rapid eye movement sleep, which you all know as dream sleep. We probably really do have eye movements that go to the side, just as we have eye movements while awake. Of course, when I read something or look up, those are movements that go up and down. This way we can also distinguish quite well between what is wakefulness and what, for example, is this rapid eye movement sleep or sleep in general.
That's exactly what I was about to say. We place the electrodes a bit higher and lower so that we can record both horizontal and vertical eye movements. Wouldn't it be great if people always complemented each other so well during such a wiring process? That would be fantastic.
But unaffordable. Then sleep lab examinations would no longer be covered by statutory health insurance. And after the latest reform of the private fee schedule, probably not by private health insurance either. But as we can see, we're slowly coming to an end anyway. We only have a few more electrodes left, Freyo.
Exactly, but let's keep working in a way that's easy on the back. I'll just ask you to stand up briefly because you need to take a look. So in this particular manner, you can meticulously rub the area, ensuring proper preparation. If I position myself precisely like this, then that's good. Now carefully place the chin electrode exactly 1 centimeter behind the prominent edge of the chin, ensuring a precise distance of 2 centimeters between the two electrodes. Subsequently, the chin electrodes are then securely placed and affixed in this designated position. And considering that everyone tends to perspire a little, it's highly advisable to use some alcohol once again to thoroughly clean and prepare the skin surface. Okay, first you insert them once and then a second time, ensuring they are firmly in place. I will then proceed to carefully attach the third additional electrode. We will strategically add a third crucial reference electrode at this specific spot, serving as a vital backup in the unfortunate event that one of the other two primary electrodes malfunctions or fails during the procedure, thereby ensuring we always have a reliable alternative and continuous data collection. I truly hope that we will clearly see in the detailed recording in just a moment precisely how incredibly important these aspects are, simply to fully demonstrate the significant difference between the rapid eye movement, or REM, sleep state, and the state of being fully awake. Normally these electrodes hold on really firmly. It could very well be that because of the ambient heat, or perhaps because the patient is feeling a little bit nervous, our specific patient exactly, that certain things might indeed shift a little from their original position. If that particular situation happens to occur, we always have readily available adhesive tape prepared, which we can then effectively use to securely fasten and hold them in place. We'll just show that briefly now. Normally that's not necessary, because it also takes extra time if you have to fiddle with these adhesive strips, but usually it's not needed. But with you, it's already a little bit necessary. In summer, attaching the cables is always a bit more difficult because of the sweat. I mean, it's 35 degrees here right now, and so-called sweat artifacts can also occur. These are very slow, high waves that simply occur because of the sweat film between the electrode and the scalp. But we hope that won't happen today. So now he can take a seat again, you can sit down again. Now we still need to attach the cables to the legs. For that, we take the patient's hand and place it underneath, about a hand's width below. All right, okay, I have much smaller hands than the patient. And now we stick it onto this muscle, flex the toe upwards like this. Exactly this muscle here, we need about a hand's width and 2 fingers width to the side, like this.
That's the front muscle on the shin bone, which we're now basically attaching the electrode to. So the so-called tibialis anterior muscle, which is on the front side of the shin bone. Not the calf muscle at the back, that would give us too many artifacts, but rather this front muscle, so to speak, which best reflects leg movements for us.
Thank you. 2 fingers width apart. And then one more little tip for everyone who actually has to do the wiring. Never put a single bandage over both electrodes, because that can create what's called a sweat bridge, which subsequently leads to unwanted artifacts and prevents you from getting a clean, accurate recording. That's why we use 2 separate bandages, which will now stick on individually. He has a few hairs on his legs, so we should just stick the bandages on to make sure everything stays in place. Especially this one up here, it doesn't really want to stick, but the one below is perfect. But it's not absolutely necessary. And we'll do the same thing on the other side now. Hold out your hand again, about 4 fingers wide. That would be here. Thank you very much. And then 2 full finger widths to the side. So we are positioned right here, exactly. And then we gently wiggle it just once. Yes, you can already see what a complicated examination this is.
But we should also certainly say it absolutely doesn't hurt at all.
No.
You applied the tape so nicely. No one needs to worry about having to go to the hairdresser beforehand or running a lawnmower over their head. None of that is necessary, especially not with this gold cup. The electrodes we use here can be applied with a normal haircut. Sometimes, of course, we also have female patients who have even more impressive manes of hair. Even then, you can still get through with these electrodes. And with the method we've just shown you, they hold quite well even in those cases.
You can also see it in the relaxed facial expression of our test subject. It doesn't hurt, there is no pain. No. Good. Great. Lastly, we have our finger sensor, which records oxygen levels to detect desaturations after a respiratory event, that is a breathing event. It can also record the pulse and the pulse wave. Would you like to say something about it?
Yes, dear viewers, you all know this from your little pulse oximeter, which you can buy at various German drugstores for a low price. Many people already take them along when hiking these days to see how they're doing, or for sports. It's nothing different. This pulse oximeter also works using red light that shines through. Maybe one more important thing, Heike. What should people avoid doing when they come to the sleep lab?
They shouldn't wear black or red nail polish and no gel nails, because then the sensor can't shine through, of course.
Exactly, and we need that to accurately measure how the breathing is. Not just the breathing measured by the chest and abdominal belts, and of course we also have our nasal flow sensor, but also naturally the oxygen saturation in the body.
Exactly, we'll put it on now with the cable facing upwards. Just pick a finger for me. We'll wrap the strap around here. Personally, I truly prefer to carefully put it down right here, securely under the shirt, so that it genuinely has a bit more stability and remains firmly in place. Here you go. And then we have our specially designed adhesive band, which is quite strong and reliable to make it even a bit more stable and ensure it stays perfectly positioned throughout the day. Okay. And as Nikki has already thoughtfully mentioned, we are still currently missing the crucial flow sensor, because this particular component is also a very significantly important part of a comprehensive polysomnography study. It meticulously records the vital breathing patterns through the nasal passages. It detects snoring by measuring the pressure buildup.
Yes, as our colleague Rainer Popo already explained during the introduction, in the past, temperature sensors were also used, but on a day like today, with an outside temperature of 36 degrees, they wouldn't work very well anymore. That's why the technology has advanced, and now we simply measure the air pressure at the nose. Now everyone might wonder, that's not much, it's just a tiny bit, but that's exactly how sensitive these sensors are today. And as Heike already mentioned, they're so sensitive that we can even detect snoring with them. We no longer need a microphone, because the small pressure changes caused by snoring are also detected by the flow measurement device.
Of course, the gold standard would be a thermistor with pressure measurement and a snoring microphone. The advantage of these pressure sensing nasal cannulas is that hypopneas, meaning reduced breathing, are detected more accurately. I haven't actually explained what a hypopnea is yet. An apnea simply means no airflow at all. It's a complete cessation of airflow, and a hypopnea means that breathing is reduced. There's still a little bit getting through.
Just like with heavy snoring.
Exactly, after some narrowing.
You're still getting some air, but, and this is important, we can detect this here by looking at the airflow. But now our chest belts also come into play again, because with hypopnea we also don't have opposing breathing movements, but rather, just like with central apnea, the movements are in sync. And that's how we can recognize it, so to speak. But honestly, nowadays, that's always the patient's fear, that with all these wires attached, they won't be able to sleep. What else do you have set up so that he doesn't have to be afraid of turning over?
So, once we've thoroughly completed the signal check in just a moment, we will then neatly and carefully bundle all of the various cables together, of course, so that the patient truly doesn't have to worry at all about potentially getting tangled up in the numerous wires when turning over during the procedure. But since we first have to do the signal check to make sure every electrode is working as it should, we always do that afterwards.
But could you maybe just show us symbolically, just very briefly, so that patients don't suddenly, otherwise I won't get into the sleep lab.
All right, you won't do that. We'll just use a little gauze pad here. Of course, there are also very professional adhesives you can use for that.
You know how it is at home. If you have cables lying around, you have to bundle them together with a Velcro strap so no one trips over them. And it's pretty much exactly the same situation right here now in this particular spot. And if you so desire, you can also effectively utilize a simple t-shirt to carefully run all of the necessary cables neatly underneath it, keeping everything tidy and out of sight. That's another option as well. In this case, we didn't do that, and we really don't need to. As I said, we've secured our electrodes well, and that's usually enough. This way the patient can move around in bed without any problems. That's exactly what we want. So no one needs to worry and think, oh, I have to lie completely still and sleep now. During a sleep lab study, please do everything just as you would when sleeping at home.
Turn your head to the left and right to see if it's free. Yes, that's important. And then we'll put a little adhesive patch here. Thank you.
Eike, what's your experience? So after many years, almost as many as I've spent in sleep medicine, do all patients eventually fall asleep, or are there some who think that because of the wires they'll stay awake all night?
What happens? Interestingly, patients who already sleep poorly at home come to us and say, now I'll show them just how badly I can sleep. But then the pressure is off and they end up falling asleep.
Yes.
They actually fall asleep much faster in the sleep lab than they do at home. Of course, there's also the other extreme, because of all the wires, especially if someone is already a nervous type.
What we usually do is professional, and in accordance with the guidelines, we conduct 2 nights of observation. We examine over 2 nights so that if someone really has trouble falling asleep the first night, we have a second night, and it almost always works out then. So among the many patients I've seen, I can hardly think of a single case where it didn't work. It's also important to note that for patients who have sleep apnea, they already sleep very restlessly. But in those cases, we basically know what's going on after just 1 or 2 hours of sleep. Nevertheless, we measure throughout the entire night so that we can also capture the REM sleep phases and see how sleep apnea or another sleep disorder, such as restless legs, affects overall sleep.
For most sleep apnea patients, the sleep pressure is of course so high, and when we have the first therapy night, that's what makes the job so rewarding. We are extremely grateful.
Do you feel like you've been reborn?
Yes.
All right, then we're actually done with the wiring up now. Now we'll briefly show you the so-called biosignal measurement, but for that we'll have to go to our computer room.
I'm now going to calibrate the biosignals, which means testing all signals and all electrodes for functionality. For this, I give commands to the patient, which they have to carry out, and I can see on the PC whether the signals are correct. Please gently and completely close your eyes, allowing them to rest for a moment. Now, with your eyes still closed, slowly and deliberately look towards your left side, then smoothly transition to look towards your right side. After that, please carefully direct your eyes upwards towards the ceiling, and then slowly bring your gaze downwards towards the floor. Please open your mouth very wide and then proceed to make a distinct, deep and resonant snoring sound, just like you would when you are deeply asleep. Please snore once, and now tense your toes and your foot. Inhale deeply, exhale slowly, and now please hold your breath for a moment. Thank you. You can breathe normally again. All the incoming signals are truly excellent, and now the recording session for the entire night can finally begin.
And how to interpret these various recorded curves and signals we'll show you in the next episode.
Goodbye, everyone.
And sweet dreams.